Thank you for tuning in to another episode of Watson Clinic Health Talk. If you're a new or expectant parent, we're sure you have questions, lots of them, and our guest on this episode is here to answer them. She's Dr. Kendra Velez, a board-certified pediatrician who treats patients from our Watson Clinic North Pediatrics location at 1430 Lakeland Hills Boulevard in Lakeland. Watson Clinic's Pediatrics Department is housed across 4 convenient locations. There's our North Pediatrics, Highlands, and South locations in Lakeland, as well as our Watson Clinic Plant City location. The department offers same-day and next-day appointment availability, and our Highlands location even offers Saturday sick visits. For more information on these services and much more, visit watsonclinic.com/pediatrics. Thank you for joining us today.
Thank you for having me. I'm so excited to do this.
So we're going to talk about newborn care.
Yes, my favorite.
Typically, when does the first appointment take place?
So typically we see the babies about 1 to 3 days after you're discharged from the hospital, right?
Okay.
So baby's born, and usually the newborns are cared for in the hospital anywhere from 1 to 3 days. And then once you're discharged from the hospital, then we will usually see them within 1 to 3 days after discharge. So let's say, usually they go home on day 2, day 3. So we're probably seeing them day 3, 4, 5. Right? Okay. Generally, we like to see patients the day after they're discharged just to see how things went overnight. And, especially with our newer first-time parents, just to kind of check in and see how the baby is doing. Some of our more experienced parents, if they've had other children, they'll call and say, hey, this is my 3rd baby. Can I come in 2 days? And so we have the ability to check some of the newborn records. And so if we see any warning signs that the baby might need to be seen sooner. For example, if they're losing a lot of weight in the hospital or they had trouble with jaundice in the hospital, then we'll have that patient probably come in, the very next day. So that's typical.
How early before the birth do expectant parents typically establish with a pediatrician if they haven't already?
So it depends. We don't require, Watson Clinic Pediatrics, we don't require prenatal visits. Those are called prenatal visits. So that is a visit generally where it's just like a meet and greet with the pediatrician. And we don't require those. Some people want to come in and, ask questions. I generally, if I do a prenatal visit, I tell the parents all the time, this is more of a, generally getting to know you session because anything I tell them about caring for the newborn is going to go in one ear, out the other, or you're just going to forget. You're just going to be like, what did she say? And you're just going to ask me again, which is fine. So generally those visits, if people come in, a lot of it is informational, which some of it is, things that you can kind of find out from our brochures and our website, like when to call the doctor, how to call the doctor, what our office hours are, those kind of things. And then some people come in just to kind of get a general feel also for just our, vibe.
Yeah.
Vibes.
Who's going to care for my baby? Yeah. But especially with first-time parents, I would imagine there's a lot of trepidation and uncertainty. What questions do they typically ask you on that first visit? And also, what questions do you typically ask of them?
So the biggest thing initially with newborns is how they are transitioning from being inside their mother to being outside of their mother. That's generally a lot of what I talk about and what we talk about, either that they're reporting to me or I'm asking of them, is generally how the baby is transitioning from in uterus life to out of uterus life. So in mom, the placenta does a ton of the work. Right? So the baby's just forming, organs are forming, systems are forming, but the mom is doing the majority of the work. The placenta is doing the majority of the work. And the first thing we do when that baby comes out and cries, we cut that umbilical cord and we separate the placenta, which is literally the baby's food source and all these things, right? So generally the first visit, a lot of it is feeding and output. That is the major thing, how the baby is feeding, how the baby is peeing, how the baby is stooling. And babies in general, because they labor, as I like to tell parents, like labor is very difficult on the mom and it's very difficult on the baby. I mean, the uterus is literally trying to kick them out. So the babies, the first 24, 48 hours generally tend to be like super tired. They feed, but they may not feed that frequently. And even if they're feeding bottle or if they're feeding breasts, they're not feeding a lot of volume, which I think is by design. Generally, I tell parents, like, I think the way that, our maker made us is that you're not going to be able to feed like 2 ounces the first day because the gut has been in this mom's body and it's just forming. Nothing is going through it, right? So then you don't want the first day to like put all this volume into this teeny tiny stomach. Like it's just going to come up, right? So I think by design, for breast milk, a lot of the first days are colostrum, which are very high in fat. It's very high in nutrients. It's very high in antibodies, but there's not a lot of volume. Like I think the average woman on a first day makes like less than 2 ounces of milk the entire day. Like when moms like pump, they'll pump like 1 cc, like so tiny. Now, liquid gold has a ton of good stuff in it. But generally it's, low volume, high reward, but also the baby is recovering from delivery. So generally what happens is they go home after the second day, which is usually when the baby's like, okay, I'm here and I'm ready to eat. And so they start waking up that first night. I have a lot of patients that come in and they're like, they were wonderful angels in the hospital. And last night we came home and he was up all night. And that's because now they've recovered. They've recovered from delivery and now they're ready to eat. Almost all lose a little bit of weight. And that's because there's not a lot of volume, right? And they're not feeding that often. And they also come out a little swollen. So they're all going to lose a little bit of weight. Generally speaking, we calculate and make sure as long as they're less than 10% weight, we kind of just watch them more. If they're getting closer to 10% weight loss, then we're watching them more closely. We're maybe having them come in for weight checks more frequently, right? So the mom also is closing a factory and opening a factory at the same time, as I like to say. Like your body is recovering from growing a human, and then now you have to be, producing breast milk. So generally that also is a big transition. And so a lot of our first visit, we're talking about mom and how she's transitioning, and then we're talking about the baby and how they're transitioning. And there's a couple clues that give us an idea of how they're doing as far as like, how they're outputting, what color their stools are, what color their skin is. So there's a lot of things that give us an idea of how they are transitioning. And the majority of babies transition wonderfully. And then there's some that we just have to help along a little bit. So that's a lot of our job. The first 1, 2, 3 visits is kind of just like establishing and figuring out how to feed the baby, what's normal, what's not normal. Babies are hilarious. They make a ton of noises. They don't know how to poop. That's the other one. A little later on, I get a lot of questions of like, they're straining and they're uncomfortable and they're trying to pass gas and they're trying to pass poop and they're just screaming. And I was like, yeah, they're pushing, but they're closing the door at the same time. It's like, you gotta figure out how to like push while opening the door. And so most of the time we spend time, the first visit generally is how the baby is transitioning, how the baby's input as well as the baby's output. And then that has a lot to do with the mother and how the mother is feeling and how the mother also feels her breast milk production too, which everybody is different there too.
Well, yeah, feeding is a big question mark, I'm sure, for a lot of new parents. How much is too much? How much is just right? How many times a day to feed them?
Generally, it's 8 to 10 feeds a day. It just seems like you're constantly feeding them. Again, I think by design, it's so interesting to me because I feel like by design, it's funny how babies know, the majority of babies know. They wake up on 2 to 3 hours because they're hungry, because they want to feed. Now, the ones that don't wake up, you have to be a little bit more, you have to push a little bit more. But I'll say the majority of our babies The parents don't have to wake them up. The babies are naturally waking up 2.5, 3 hours after the last feed to feed again. It's only those ones that, tend to be a little lazy, need a little help, that, you have to put the alarm on and say, okay, at this mark, kind of start getting them undressed and uncomfortable. But generally, like, it's like human nature to them. It's like kind of amazing.
Yeah. Let's talk about vaccines with newborns. What's the recommended schedule? Which vaccines?
So for newborns, so one of the big things that in the hospital as well, and it's not a vaccine per se, but it's not a vaccine, not per se. It's not a vaccine. Vitamin K is a shot that they usually get in the hospital. Super important. Vitamin K, it helps with clotting. And so if you have a deficiency in vitamin K, you get bleeding. Most dangerously, bleeding in the brain, right? So babies are naturally born with a vitamin K deficiency. This is why usually within the first few hours, they give them a vitamin K shot. And so people always ask about why it's so important. And if they don't get it, what could happen? And so we talk about, if you don't get it, then you can have bleeds in the brain, bleeds in the gut. And so these babies present with seizures and altered mental status. And so generally speaking, very important, because it's not something that we could give orally. There's oral vitamin K, but it doesn't give them the sufficient funds that they need for the clotting. And so that is one that is given in the hospital. And then the other one that's offered in the newborn period is hepatitis B. Hepatitis B, liver virus. The problem with hepatitis B is if they get hepatitis B when they are infants, then the likelihood of chronic liver disease is going to be 90%. Like 90% of kids that get it in infancy will have chronic liver disease. And chronic liver disease leads to liver failure, cirrhosis of the liver, transplantation of the liver, or requiring transplantation of the liver. So years and years ago, because we've had this vaccine for a very, very long time, and we used to give it more for like what they called, quote unquote, high risk groups, right? So the transmission that we're trying to prevent here is from mother to baby, right? Mm-hmm. So the hepatitis B virus, if the mother has active hepatitis B, can pass on to the baby, and the vaccine can prevent that from happening. So this is why they usually give it within 12 hours of birth. And we used to do more like high risk for give the infants that have the hepatitis B positive mothers, or if the mother had other risk factors for hepatitis B, whether it's IV drug use or high risk sexual activity, those kind of things. The problem with that is that, in our country, not 100% of people don't get prenatal care. And so then you would run into the case of maybe the mom hasn't been tested for hepatitis B, or maybe the mom was recently infected with hepatitis B and just, hasn't shown the positive titers. So back in the 90s, I believe the late 90s, we went from doing more high risk hepatitis B vaccination to universal newborn hepatitis B vaccination. And lo and behold, we went from 20,000 cases per year of hepatitis B in children to less than 20. Ooh, so wow. Over 95% reduction, wow. Which is amazing, right? And so nobody really knows why hepatitis B has been so controversial lately. I think a lot of people in the, current environment are talking more about, whether we need to go back to giving it to more high-risk patients. But the truth is, we've already tried that. We've already tried to give to just high-risk babies, and it hasn't worked. Kids fall through the cracks. So something that's been given now, what's that now, 20 years, 30 years, late 90s, 30 years, very little side effects, safe, effective. Really, it's something that we recommend all of our patients to get. The one that's a little bit recent, although not too recent, is there is a RSV monoclonal antibody shot called Beyfortus, which we have started offering at our clinic this year. RSV is respiratory syncytial virus. It's a very common respiratory virus. It's, every year we have RSV season. And here in Florida, actually, because of our tropical weather, we tend to have almost year-round RSV. Up in the north, the season is about like 5 or 6 months. And for many years, we had a shot called Synagis, which was a monoclonal antibody. It was a monthly shot that you would give for 5 months to kids that were high risk, mostly premature babies, babies with heart conditions, babies with lung conditions. And now we have the ability to have one shot that covers them for 5 to 6 months. So not a vaccine per se in the fact that we are making their bodies create the antibodies, but we're actually giving the babies antibodies to RSV, which is pretty neat. And so the end there, and this is what I tell parents, it does not prevent them from getting RSV. The studies showed that the hospitalization rate and the rate of lower respiratory tract infections, so pneumonias and wheezing and the kids getting very, very sick and ill, went down significantly with Beyfortus. So that's something that has been very successful recently, and so that's probably been around the last, probably less than 5 years. But it's not something that's, I say to parents it's new, but it's not so new because we've had Synagis, which is just another version of that monoclonal antibody.
Yeah.
And I think because now we're not just doing it for high-risk babies, we're doing it for any healthy baby between 0 and 8 months, I think we're going to see hopefully a significant decrease in RSV hospitalizations for babies. There is a vaccine for the mothers that they can get between, I believe it's 32 and 36 weeks gestation. And if the mother has the RSV vaccine, the nice thing about that is that the mother passes the antibodies through the placenta. And so those babies don't have to get the monoclonal antibody. They actually get protection from the mother. So there's 2 ways to get protection against RSV, which is pretty neat.
And the RSVP, the RSVP. The RSV.
It's going in the blooper reel.
The RSV vaccine, you administer it when during the babies?
So you can do it anytime after birth. So it's indicated for any child between 0 and 8 months.
Okay.
We offer 2 doses in our office. If they're less than 11 pounds, they get the 50 microgram dose, and if they're more than 11 pounds, they get the 100. Microgram dose.
So we mentioned Hep B, RSV, the vitamin K injection. So for newborns, that's the schedule?
For newborns, yes.
Okay. Bathing. How often should you bathe a newborn?
Not often.
And why is that?
Well, one, they don't sweat. They don't smell. You probably do need to bathe them if they've had you know what? Yes, a number 2. Generally, probably like once or twice a week is probably fine. They're also very slippery. I'll tell you a funny story. When I had my daughter 10 years ago, we came home from the hospital. They give them a bath in the hospital because when you come out, you have the vernix, which is like the coat, so they wash that off. So we came home, and then 2 or 3 days later, I was like, I need to bathe her. But I had been a pediatrician for about 10 years at the time, and I didn't know how to bathe a baby because no one had ever taught me that. And my husband, who's not medical, says to me, what do you mean you don't know how to bathe a baby? I was like, nobody teaches you this. My cousin came over, and I said, hey, can you help me bathe the baby? I'm like, I can do a lot of things in newborn care, but I had to learn. That one I had to learn. And they're very slippery.
Yeah.
It was even I remember having a little bit of palpitations myself, and I took care of babies all the time.
And when do you start worrying about a fever?
In the beginning, first 2 months, fever is always super dangerous because their immune system is so young. They don't have any memory, and they can get an overwhelming infection very quickly. So the guidelines now for the less than 1 month olds for sure are going to be get a full workup. They're in the hospital for 2 days. They get blood culture, culture of the blood, culture of the urine, culture of the spinal fluid. So any baby less than like 30 to 60 days is kind of that window where they will have, we will need to make sure that they're not having any signs of overwhelming infection, and usually those are monitored in the hospital, which is why I tell my parents to try to limit as much as possible exposure, because even if they have a virus, it's so hard to tell a virus from a bacteria, something that could like be more overwhelming to the baby. And especially this time of year where like everybody is sick, everybody has a flu, and say FaceTime is a wonderful thing because the cousins, the siblings, the neighbor's kid that wants to come see the new baby, but they're just full of snot. I'm always like, oh. I joke with my friends that I'm like the one friend that won't visit you in the hospital or soon after, because I just don't want.
So is this the first 2 or 3 months you kind of have to remain in a bubble?
Yeah. A little bit. I mean, this doesn't mean that you can't like walk outside or, it's so funny. People take it so literal. Like, I have parents. I actually had a mom today ask me, she's like, can we walk outside? I was like, yes, please walk outside. Like, if you're going to go to Bonnet Springs and like have a family picnic, like, sure, like cover the baby. They shouldn't be in direct sunlight. But I think my daughter was like 6 weeks old, and I went to a restaurant and I sat outside and my husband was panicking, and I was like, we're outside. It's fine. Like, I just needed to have a sandwich. It was like not even like lunchtime. It was like 2:30 in the afternoon. There was like 2 other patrons, and it was literally like we were sitting at a picnic table outside. I'm like, we're okay.
So how often should, barring any sudden illnesses like a fever or what have you, how often should new parents bring their baby to the pediatrician?
So our schedule is the first visit, which is 1 to 2 days after discharge, and then we see them at 2 weeks, and then the next one after that is 2 months of age. However, in between there, they can call us for anything. We see, kids for a mirage of things. If they're gassy, if their poops change, if they're not feeding well. In office, we see newborns, anything that's out of the ordinary. Certainly we have you guys bring them in, we'll weigh them, we'll examine them to make sure that there's nothing, that everything is, at normal newborn things and not anything that needs more attention, right? The only time we're generally not going to see them in the office is fever, just because they need more testing, and usually they're not going to be in an office setting. They're going to be in a hospital setting. But generally speaking, we see them for so many things. Rashes, changes in stool, changes in urine, changes in feeding pattern, gas and colic. That's like a normal one. Reflux and spitting up. That's like very common too, because babies' stomachs are really tiny and the distance to the outside is very short. And so they can have a lot of spitting up. That's pretty normal. I just explained to the parents that the newborn gut is very leaky. It's very immature. It just doesn't know what it's doing yet. It's it's a system we're going to have for 100 years, right? So the first 3 months being wonky, it makes a lot of sense. If you put new pipes into your house, you're going to have to flush the water. You got to flush all the bubbles out. Like, that's literally what's happening in the beginning. So a lot of the beginning is mostly a lot of it is digestive. It's a lot of like gut and stomach and poops and feeding, and that's the majority of the problem. But the nice thing is the majority of the time it's reassurance. A lot of our job is reassurance that the baby is doing exactly what it's supposed to do, and they struggle because they're babies.
Yeah, and I would think that the access to you, if you have any questions, the ability to access your office or schedule possibly a same-day appointment if they need to come in is a very important consideration.
Absolutely. I tell my patients to call or message all the time. We can see them usually within 24 hours. We'll see them in the office. And if they have any questions, we are available literally 24/7. So when the office is open, the nurses are fielding all types of questions. And then even if there's anything at night where you think, oh my gosh, do I need to go to the emergency room? Can this wait until tomorrow? That's why, our physicians and nurse practitioners are on call every single day, 365. Mother's Day, Christmas Day, New Year's Day.
Any day at all.
Any day.
You mentioned at the beginning that when I said that we were going to discuss newborn care, you said that's my favorite. What do you love about it?
I really enjoy the teaching aspect. I feel like a lot of my job is reassurance and holding hands and making sure that because you come home with this one baby, and I've seen thousands of babies, and they all do the same thing, but you don't know that because you don't know the other babies. And so I enjoy that aspect, and I joke with the parents because they'll come in with, the first visit, they'll have like 25 questions, and the second visit, they'll have 20 questions. And by the time they're like 2 or 3, you're not even having any questions. It's like so nice, Like I did my job. I like taught you well,
Yeah, you not only see the babies develop, but you see the parents come into their own.
1,000%.
Yeah.
Because everybody is so unsure of themselves, right? But I tell my moms and dads all the time, like, trust your instincts. Like, natural instincts are super important when it comes to, I just feel like we are like prepackaged with some of that. Like when something is off, usually something is off. You know what I mean? Like I listen a lot when something is like somebody who's with the baby 24/7 and they see like an acute change, like something happened and it's so different. You have to like perk up your ears at that.
Listen to your instinct.
That's like your spidey sense right there. You have to be like, wait a minute, like why,
Did you always want to be a pediatrician?
I did. When I was a kid, I used to line up my baby dolls and either check them or I would read to them. I did always enjoy like sciences and math. That's like always like my favorite subjects. And when I went to med school, I thought, I really wanted to be a pediatrician. And it's funny because a lot of people go to med school thinking they're going to do pediatrics. And then people actually do pediatrics and then they go, yeah, not for me. Like I had like 2 or 3 friends that we were doing the rotation that are like, yes, this is what we want to do. And then they like a week later, they're like, yeah, this is not for me. No, I do think it's a calling because you have to be really good with the parents and with the kids. And that, it's a little bit of like detective work too, because your patients can't talk. So they can't tell you. No, I'll tell you. The reason I love them is because they could be sick as stink and they'll still be smiling and wanting a sticker and a lollipop.
Yeah, that's a scary part of it to me is what does this crying mean? Trying to decipher, since they can't talk to you,
right?
So you have to be like the baby whisperer.
A little bit, but I'll tell you, the babies will tell you too, because they won't feed. They won't feed, or they won't pee. Like they won't do their basic functions. So if I have a 5-year-old, I know they're sick if they're not running around like a Tasmanian devil. You know what I mean? If they're on the couch and they're wanting to just like lay on that couch, you're like, what's wrong with you?
Right.
Whenever my daughter would be like, I'm just going to sit here. Like, you're going to what? Are you okay? Like, almost always, my hand goes straight to her forehead. Like, what's happening? But a baby, their main activity is feeding. So they'll let you know. So usually I tell parents all the time, if they're feeding, most symptoms that you're telling me, you'll kind of like try to figure out what's normal, what's not normal. But if they're feeding, my guard is like a little bit like less.
Yeah.
Okay. If they're seeming hungry and they're finishing those bottles, I'm a little bit less nervous than when I go in there and they're like, they haven't fed in a couple of feeds. That's always not normal.
So is there anything that we missed? Any topic that you think you'd want to bring up? Or
I don't think so. I think we covered a lot.
Okay. Yeah, we talked about everything newborn baby related, RSVP vaccines.
RSVP.
Thank you so much, Dr. Velez. This has been great.
It has been fun. Thank you so much. Thank you for having me.
That's it for this episode of Watson Clinic Health Talk. For more information and to schedule an appointment with Dr. Velez, call 863-680-7337 or visit watsonclinic.com/Velez. And for additional details on our pediatrics department, visit watsonclinic.com/pediatrics.